Right, I go. Good afternoon, everyone. Thanks very much, Paul, for asking me to speak. As you mentioned, I'm going to talk a little bit about ASD and PFO closure. I just wanted to talk a little bit about the sort of pathophysiology and the anatomy and the slight difference between PFO and ASD, because I think sometimes it's not well understood. On the left-hand side picture, you've got a PFO, and you'll hear people describe a PFO as a flap type valve. And you can see there where the arrow is, that it's this little flap valve in the atrial septum, obviously between the two atria. And I'm sure you're all aware, but just as a reminder, this is a embryological remnant.
Yeah, so that's what you're moving around it now.
Okay, so, how about now?
Yeah.
Okay. All right, great. So sorry about that. So hopefully you can see that now. So on the left-hand side, you've got a PFO, which is this flap type valve in the atrial septum, which you remember is required embryologically when you're not breathing oxygen. You get oxygen from your from the placenta, and this flap type valve allows venous blood to come into the right atrium and then actually bypass into the left atrium and go into the systemic circulation. Now, once you're born, you start to breathe air and oxygen. Left atrial pressure increases a little bit, and this valve is designed so that as left atrial pressure increases, the flap comes across the atrial septum and seals off, usually within the first hours or days of life, but certainly in the majority of people within the first year of life. Now, it's very common to have that patent into adulthood, and that's one of the topics of the talk, obviously, in up to about a quarter of the percent, 25% of the population, so a quarter of the population. But even when it's patent in adulthood, as left atrial pressure is higher than right, for the majority of the time, this is usually sealed off as this flap is pushed up against the atrial septum. And there's only certain circumstances, or the majority of the time, there's certain circumstances where right atrial pressure goes up above left atrial pressure, and that allows a transient amount or a small amount of blood flow to go from the right atrium to the left. And it's that small amount of blood allowing venous blood into the systemic circulation that is the concern with the pathology of a PFO, and I'll talk more about that shortly. But generally, PFOs don't offer a significant hemodynamic load on the heart for that reason. On the right hand side, you see a secundum atrial septal defect, which, as you can see, is a hole in the atrial septum. And as there's a hole and no flap, that means that you get, in the context of left atrial pressure being higher than right, you get continual volume load from the left atrium to the right atrium and into the right ventricle, which causes a volume-loaded right ventricle, right ventricular dilatation, and then the sequelae of that. So just a reminder, really, in most circumstances, ASD is the defect that gives you a volume load, and PFO is not a hemodynamic concern. It's just the opportunity for a small amount of venous blood to be transmitted into the systemic circulation. I'm sure you're all very familiar with this, but the cornerstone of diagnosis of ASD and PFO is transthoracic echocardiography. In an ASD, you look for resting color flow across the atrial septum. You also might look for some associated abnormalities, particularly with PFO. So an atrial septal aneurysm, it's important to be aware of that, particularly if you're doing TOE. Essentially, the definition of, it's a slightly unusual term, but the definition of atrial septal aneurysm is redundant atrial septal tissue that moves either side of the midline more than a centimeter. You can also look for a prominent eustachian valve. That's another embryological remnant, and that in the embryological circulation directs IVC blood to the PFO because that's what you want, and that can be a feature of higher risk PFOs in adults. It's unusual to see a PFO just on resting color flow. You usually have to do a bubble study, and I'll show you an example of that in a moment. And that is done at rest and with a Valsalva. The Valsalva being creating that situation where you get a transient increase in right atrial pressure to open the PFO flap. On a baseline assessment, it's important to assess right-sided pressures, particularly in atrial septal defects, but also in PFO, because ASDs can be associated with pulmonary hypertension and significant pulmonary vascular disease. And if that is detected, then that warrants more careful assessment. And in that situation, closure might actually be contraindicated, but I'll go through that a little bit more in a bit of detail. Transesophageal echo, which you're all very familiar with, we sort of reserve for more difficult cases, those that are unclear in atrial septal defect, to assess the rims for device closure. And I've seen that Dr. Smith's got some very beautiful transesophageal echo pictures for device closure. And other imaging, non-invasive imaging, CT and MRI, we often use, perhaps not so much in PFO, but in ASD, to get a further assessment of the right ventricular size and function, a shunt calculation, and also to check pulmonary venous drainage, as although classically sinus venosus ASDs are associated with abnormalities of pulmonary venous drainage, it can occur with secundum ASDs as well. So it's important to know that ahead of time, particularly if you're considering device closure. This is a bubble study. So this is an apical 4-chamber view done at rest, although you see the patient does cough or sniff halfway through it. Apologies, it's a slightly amateurish picture, but you'll see bubbles fill the right-hand side of the heart, and then very quickly within 1 or 2 cycles, cardiac cycles, you'll see some bubbles come into the left. And if you watch it again quickly there, hit the right, you see a few in the left, then the patient coughs or sneezes, and you see another big cloud of bubbles going into the right. And it's important to do that maneuver, as I mentioned, to increase right atrial pressure, because if you're in a situation where left atrial pressure is higher, you might not get any bubbles to cross the atrial septum. So what are the symptoms, or in what situations do we diagnose ASD and PFO? I mean, they are slightly different situations, although there's some overlap. As I mentioned to you before, PFO is present in 25% of the population. It's usually asymptomatic because there's no hemodynamic burden, but it's important in patients who have cryptogenic stroke. And that's the vast majority of, well, that's the main situation in which we close PFOs. For ASD, because you have this hemodynamic load, patients are more likely to have some symptoms, usually exertional breathlessness. They may get palpitations and at risk of atrial arrhythmias, but often, as the right ventricular volume overload is very well tolerated, often diagnosis of ASD is incidental when patients have imaging for some other reason. Again, it's also important in cryptogenic stroke because you can have paradoxical embolic phenomenon through an ASD as well as a PFO. PFO's importance in stroke has been known for quite a long time now. Back in 1835, Professor James Jeffrey in Glasgow first described the fetal circulation and realized the importance of the foramen ovale. And then about 40 years later, Julius Conheim, who's this chap in the picture, did a post-mortem on a young woman who succumbed to a large MCA stroke and had a concomitant DVT. And she had a large PFO, and he theorized that perhaps clot had gone from the DVT through the PFO and caused her stroke. And there's multiple examples later of postmortems and in vivo imaging of thrombus trapped in PFOs. I won't dwell on this too much, but just to give you a little bit of context about PFO closure and some of the trial data, it's been very extensively investigated in a number of randomized controlled trials. The top 3 of them are sort of pre-2016 trials, and the outcomes of those, although they did suggest a benefit of PFO closure in the context of cryptogenic stroke, it wasn't totally conclusive, and the jury was out. But since 2016, there have been a few more trials and also an extended late follow-up of the RESPECT study, which is probably the most well-known PFO closure trial. And it now shows a clear benefit of PFO closure over and above medical therapy, which is largely antiplatelet therapy in cryptogenic stroke. And just a couple of Kaplan-Meier curves from those studies. You can see RESPECT on the left. The purple line is those patients that underwent PFO closure with an Amplatzer occluder, which was the original occluder. And the orange line is those that had medical management. And you can see that after sort of 18 months, the lines start to separate. And then when you go out to 6 or 7 years, you get quite a marked change in outcomes. And a similar story on the closed study on the right-hand side. And it's perhaps just worth mentioning that some of the early studies probably didn't show as much of a benefit because they were only following up patients for 1 or 2 years. And you can see that particularly on the RESPECT study, which initially published a 4 or 5 year follow-up and then published a 9 to 10 year follow-up, you can see at 5 or 6 years there's a marked difference between the risk between the two groups. And that's probably because even if you have a PFO-related stroke, the risk of having another event is quite low, particularly on medical therapy. However, so you need to follow up patients for quite a few years before you start to see the risk benefit of PFO closure. But that's quite important in this patient population. They're often young, in their 20s or 30s, so you want to protect them for 10 years plus rather than just 1 or 2 years. Current indications for intervention. So as you might imagine, with previous data not being perhaps quite as convincing, PFO closure has been quite a controversial topic in recent years. But in 2019, with all the latest data, it was agreed by NHS England that PFO closure would be offered on the NHS. And these are the criteria. So PFO is commissioned for patients around the age of 80, because that was the sort of age cutoff in most of the studies. And you have to have suffered an ischemic stroke or TIA with positive brain imaging confirming ischemic damage. And the most likely cause has to be paradoxical embolism. How do you know if that's the most likely cause? Well, there's a few other criteria lower down, but essentially you have to make sure that people don't have atrial fibrillation, which is a higher risk for stroke. No other obvious causes, particularly local vascular causes such as a dissection, which is another major cause of stroke in the younger population, and not lots of cardiovascular risk factors. As you increase your cardiovascular risk factor profile, the likelihood of your PFO being important in stroke reduces significantly. And all patients being considered for PFO closure need to go through an MDT involving a stroke clinician, an interventional cardiologist, and the panel has to agree that they think probably paradoxical embolic phenomenon is the most likely reason for the stroke. Just wanted to talk for a short minute about something called platypnea orthodeoxia. Now, the vast majority of PFO closure I mentioned is in the stroke population. However, this is something that is a rare indication for PFO closure, but perhaps something you might see more often in intensive care. So platypnea orthodeoxia is this slightly unusual situation where patients suffer with positional desaturation. And it's not only in that situation that we see it, and many of you may have come across such a thing in intensive care patients who've been ventilated, and particularly those who have had lobectomies or have significant aortic root dilatation or kyphoscoliosis. It can happen sometimes after chest trauma. And essentially what we think happens is the patients have a large PFO, as shown on the picture in the right, but I'll go through that with you in a moment. And there's some alteration in the anatomy that has encouraged streaming of the IVC or venous blood through the right atrium and through the PFO and into the left atrium. And because of the size of the PFO and the constant streaming, you now don't just have a transient amount of blood going from the right to the left, but you have a significant volume load, which is enough to actually cause desaturation. And the positional nature is because in different positions, the PFO flap will be held open or shut. And classically, as I say, platinum orthodoxia is patients who desaturate when they sit up. It's important to exclude pulmonary hypertension because another cause of right to left shunting through a PFO or an ASD is actually elevated PA pressures and right ventricular pressure. And it's important to make that difference, because if you are shunting right to left because of pulmonary hypertension as opposed to streaming, then closing a PFO will make the patient worse. On the right hand side, this is a 3D TOE picture of one PFO in different stages of the cardiac cycle. And for those of you who are perhaps not that familiar, imagine you're in the left atrium. This is the PFO flap, so it's a huge PFO, and this is the sort of tunnel of the PFO going back into the right atrium. And you can see it a bit clearer here. So now the PFO is really widely open. This is the flap of the PFO, this is the tunnel, and you're seeing back into the right atrium. And you can see that throughout the cardiac cycle, this PFO is open. And if you have streaming of venous blood, that allows continual venous blood from the right atrium into the systemic circulation and can cause desaturation. And in this situation, PFO closure is very effective at reducing that. A few comments on closure devices. There's a large number of closure devices available. PFO and ASD devices are very similar, apart from a few technical differences, but the way they are made is very similar, and they're all a bit of a variation on a theme. So they largely consist of a significant amount of an alloy called nitinol, which is an alloy of nickel and titanium, and that's used because it's very flexible. You can see on the left-hand picture here, hopefully, this nitinol is now woven into a mesh, and it's woven into a mesh in such a way so you have a disc here which sits on the left atrial side of the PFO, a waist here that sits within the tunnel, and then a right-sided disc here. And you might be able to make out that there's a PTFE patch sewn into the device, which helps with endothelialization and sealing. And then I'm just holding the little end of the device here, which is where you connect it to the delivery system. This is a slightly different device, but used in similar situations, made by Gore. And the idea behind this was to be a little bit softer. There's the grey wire here you can see is the nitinol, and the rest of the device is made up of Gore-Tex. I've just got a little animation here to show you a PFO closure procedure. Sorry, I'll just turn it. Andrew, that's your room. I'll leave that. Where is it? Yes, not done. Can you just turn it off that? But then they won't be able to hear me, will they? Ah, there you go. How did you do? Oh, it just disappeared. I'll just let that play through. Hopefully you can hear me. You can see it.
That's working now. Yeah.
Oh, yeah. A model of the heart here, you can see a wire is being passed up from the IVC into the right atrium through a PFO, and then into the left atrium. You then place that actually in the left upper pulmonary vein for stability. And then a catheter is being passed over it. They just show that puff of bubbles to show you that the PFO is open. It's passed over into the left atrium. The wire used to deliver it is then taken out, and then you're just left with a tube, a delivery sheath from the IVC through the PFO and into the left atrium. and then you can use that to deliver one of these devices, which, as mentioned, is very flexible, so you can push it through a delivery sheath, and once it pops out the other side, it has a memory, so it remembers its left atrial disc, right atrial disc, and then you check that it's in a good position. And once you're happy, you then release it from the delivery system, and it stays in situ. And that's just a picture of one of the type of devices. I'm not going to show you too many of these pictures because Dr. Smith has got lots of TOE pictures, but I just want to play you this if it will let me. Bear with me a minute. Yeah. Well, as I say, Dr. Smith's got lots of transesophageal echo pictures to show you, but essentially, the picture on the left is a TOE. So, as I'm sure you're aware, the left atrium is here. This is the right atrium. The aortic valve is in short axis. This is that wire that I showed you in the animation, coming from the IVC up through the PFO and then off into the left pulmonary vein. This is the atrial septum, and you can see that this is the sort of flap type valve of the PFO. And the wire here is opening up the PFO, but you can see how when left atrial pressure is higher than right, it would be sealed across here. And then on the right-hand side, this is now a very soft balloon, a sizing balloon that's been passed up along that wire and into the PFO and being gently inflated. And you can hopefully see that the balloon becomes wasted here. And this gives us an idea of the tightest area of the PFO and also an idea of the tunnel. And unfortunately, no. So this one will play. This is just a long loop of a device being deployed. So you can see that left atrial disc being put in the left atrium, everything's being pulled back to the atrial septum, and then the right atrial disc is being opened on the right atrium, and then that's the device in place. I'll let that play through once more. So left atrial disc, everything's being pulled back to the atrial septum, and then the right-sided disc. And then this is just essentially that, but you can see it sort of like a bench test. So this is the delivery sheath. You can see how the device comes out the delivery sheath, initially in a bulb, then with the left-sided disc, and then the waist, and that's the start of the right-sided disc. And you can see the right-sided disc comes out, and then it all opens up and flattens on either side of the defect. There's a device in place. This is quite an interesting picture because you can see the left atrial disc here and the right atrial disc. Anatomically, there's sometimes some things that make the procedure difficult. You can see the SVC limbus here is quite thick, which can sometimes make it difficult to see a device. And I mentioned to you a eustachian valve. You can see this patient's got a very prominent eustachian valve here, which is just directing IVC blood straight across the PFO. And you can see why that's a risk factor for paradoxical embolism through a PFO. And on the right-hand side, this is just doing a push-pull test. Once you've got a device in place, you just want to check it's stable and it doesn't come through the defect, so you can do a little push and a pull. Just going on to ASD, I mean, procedurally wise, it's quite similar, although the devices are slightly different and it can be more challenging because you've got a much larger hole. But indications for intervention are slightly different. I did mention to you that cryptogenic stroke is an indication, and that's in there. But the other indications, as per the ESE guidelines, are a significant shunt, which essentially just means that the right heart is volume overloaded, and that is an indication for closure regardless of symptoms, but obviously if patients have symptoms as well, that's an added indication. And as mentioned here, pulmonary vascular resistance of less than 5 Woods units. Secondly, it says on here, device closure is a method of choice for secundum ASD when applicable. So we usually try device closure first unless they're very large. There is this group of patients, and I mentioned to you before, to be aware of pulmonary hypertension. So some patients with ASD do have pulmonary hypertension. Whether or not it's related to the ASD itself or it's incidental pulmonary hypertension isn't clear and is a bit controversial. But in patients who have a suggestion of pulmonary hypertension on transthoracic echo, they should go on to have an invasive cath to check, and those with an elevated pulmonary vascular resistance may benefit from pulmonary vasodilators. Certainly, you wouldn't want to close the defect without thinking about it carefully, and some patients would go on pulmonary vasodilators to bring the pulmonary pressure down, and then might be considered for closure later. In those patients who have established severe pulmonary vascular disease and essentially Eisenmenger physiology, so they're shunting a significant amount of time right to left, then closure in ASD is contraindicated because they're requiring the ASD to offload the right ventricle because of the severe pulmonary hypertension. And if you close the ASD, that escape valve is gone and patients deteriorate very rapidly. So it's quite important to have an idea of their pulmonary pressures when patients are going for procedures. This is some fluoroscopy of an ASD closure procedure. So this is, as you've seen before, a wire from the IVC going up through the right atrium, through the PFO and into the left upper pulmonary vein up here. This is one of those very soft sizing balloons. You can see some markers on here that you can use to measure, and you can see an indentation. What you're ideally hoping for is an indentation on either side of the balloon, just to get an idea of the size of the defect, because sometimes it can be some very floppy atrial septal tissue, and you want to get an idea of where you have a bit of tension to size it for implanting a device. This is a delivery sheath that's been exchanged in the left upper pulmonary vein, and we've just done a contrast injection so you can see the left upper pulmonary vein. And then this is the device being delivered through the delivery sheath. You can see it just being pushed. That's the tip of the device being pushed out of the end of the delivery sheath. Can be a little bit difficult to see now, but you should see the left atrial disc open. Everything gets pulled back towards the atrial septum, and then you'll see the right-sided disc open. There we are. And this is a bit tricky, but you can see the device just behind the TOE, and it's just being released. You can see the 2 dots of it, and then you can make out the discs. Admittedly, it's a bit difficult to see on that. Just a word on device embolization. This is not what you want to see the following morning. So this is a patient who had a very large ASD, and we put a 30 something device in. And just to give you an idea of how big that means, the left atrial disc, which is the bigger disc, is nearly 6 centimeters, so 5.5 centimeters. So it's a big disc, and this has fallen out and gone into the pulmonary artery. And so we had to try and fish this out. This is fluoroscopy. This is a lateral view. So the front of the chest is here, and you can see we've got a catheter coming up from the IVC again with a big sheath. And then this is a snare, which is essentially just a lasso that you try to grab on. Hopefully you can see it here. So we're just trying to grab onto this little nubbin on the device, which is essentially where the delivery system attaches. And if you can grab with a catheter and the lasso, you can then bring it back into a sheath and take it out. And this is just a slightly other view, so you can see the device from the side and the snare just behind it here. Just a couple of words on hemostasis. If you're looking after patients during these procedures, it's important to know how hemostasis is achieved. They usually can be very large sheaths, particularly for ASD devices up to 16 French. So there's a couple of ways that we close them. You can use a ProGlide, which you might be familiar with from other percutaneous procedures. And essentially, this is just a percutaneous suture that's delivered, usually pre-deployed. So you place the foot plate, you can see the foot plate here in before you put a large sheath in, and then you get two ends of a suture out, which can be clipped. And then once you've finished the procedure, there's a special tool, because one of the two sutures have a little knot on it, and the knot can be pushed down onto the top of the vein to seal it off. So you've got a foot plate on the wall of the vein, and then a little knot that gets tamped on to seal it off. Other ways are this Z suture, which does look a little bit barbaric, and essentially it's just getting two flaps of skin to try and tamponade the vein. So you take a large chunk of skin below the sheaths and then a large chunk of skin above the sheath here, and then you tie them tight as you're removing the sheath, and that essentially just causes two bits of skin to tamponade the vein to allow it to heal over. They shouldn't be left in for too long, for sort of 4 to 6 hours maximally, because you don't want to occlude the vein for too long. Risks of the procedure: overall ASD and PFO closure procedures are low risk, but it's obviously not without risk. Can be done on a day case or overnight stay, either with local anaesthetic or general anaesthetic. If you use, we obviously need some imaging for the procedure. We use X-ray, and if we use general anaesthetic, we use transesophageal echo. And if under local anaesthetic, you can use intracardiac echo, which you can image the atrial septum with very well, although perhaps not quite as clearly as TOE. Less than 1% major complication rate, and those complications are stroke, less than 0.5%, device embolization or erosion, which is less than 1%. And if that happens, there may be a requirement for cardiac surgery. Other complications are not quite as serious and are in the region of 2 to 3%. Vascular trauma because of large sheaths, but we use ultrasound guided puncture, and it's a venous puncture, so thankfully that's quite rare. Arrhythmia, particularly atrial fibrillation, can be transient peri-procedure, but also in the first few weeks after a procedure. Infection in the context of a prosthetic device, but it's extremely rare for these devices to become infected. And in the context of PFO closure, sometimes you can end up with a residual shunt. Usually after these procedures, we follow people up about 6 to 8 weeks. In the context of a PFO and a stroke, we'll do a bobble study to ensure the device is sealed. And the patients will usually require some course of antiplatelet medication while the device endothelializes. And that's pretty much it from me. So if you've got any questions, I'll try and answer them.
Do you ever get through this?
Yeah, so there are, it's rare, but there are cases of that, and that's why we give antiplatelets. So usually people, we tend to here give one antiplatelet for 6 months. And the theory behind that is the endothelialization process usually takes 3 to 6 months, although it can take up to a year. And until that process happens, then there's a theoretical risk of developing thrombi on the device.
And it's still thrombus more like to be right-sided being to PE, or is it left-sided?
It can be either, actually. So there are cases of people presenting with stroke or PE, but yeah, it's very, very rare. It's very rare.
The other question was, in the small but significant PFOs that had regen strokes, how do you make CG stunts like push the wire until you find the hole? Like, technically, because I mean, it looked tiny in that video.
Yeah.
You can see on the video, it's slot straight in the first time.
Yeah. Yeah, it can be difficult. So the IVC is directed to the PFO. So often in a big PFO, you'll pass a wire and a catheter and it'll just shoot straight across, which is why they're potentially having paradoxical embolism. But sometimes they're very small and you have to fiddle and use a smaller wire or a slippier wire and try and get through it. Yeah, it can be a bit tricky sometimes.
You sometimes see delayed heartbeat.
Delayed.
Heartbeat
From ASDs? Not usually, no. No, not that, yeah.
Oh, that happens straight away. Or does it happen?
I mean, so what you do see is the hemodynamics change very quickly. So you often see the RV size come down, you know, by the following day. Sometimes in a big defect, you'll see it come right down. But function-wise, don't really have a noticeable difference. I mean, you might have, because there's a, you know, like when you lose regurgitation and things like that, but you don't have a noticeable functional difference in RV function. These are largely people that have good preserved RV function.
And are all types of ASD suitable? I mean, obviously the rims are the things that tend to big ASDs with no rims. But in terms of the actual location of the ASD, is there anything you could try and pose into that?
Yeah, I think Dr. Smith's got some more information on that. So I didn't go through that in too much detail, but yeah, there's all of the rims around it. Usually the one that's most commonly absent is the aortic rim, which you can get away with. The one that's most concerning when it's absent is the inferior rim, because there's higher risk of embolization. But it's a matter of taking up all the rims together. And you know, if you've got more than a third of the whole of the rim missing, then you're concerned whether or not it's inferior or anterior or superior.
Not just limited to closing secondum ASDs, you can tackle with sinus venosus one.
So for these sort of devices, it's purely secundum ASDs because of the way they're designed. Primum ASDs need surgery because they usually involve the crux of the heart. Sinus venosus ASDs, there has been a move over recent years to repair those percutaneously, but it's not with a device like this. It's with, if you imagine a superior sinus venosus ASD with anomalous pulmonary venous drainage, the way it's actually done is with a tailor-made covered stent. So it's a covered stent that goes into the SVC, and it's quite difficult to explain without looking at a 3D model, but it sits in the SVC and in the right atrium, and it excludes the anomalous pulmonary veins. It's only for specific anatomy, but it excludes the anomalous pulmonary veins so that they can drain through the sinus venosus ASD into the left atrium, and then the bottom of the stent is flared so that it seals the right atrium. So that's something that's being used more and more recently, but it's a very different technique. Did you want to add anything on that?
No.